This oral presentation is a summary of the findings of a recent manuscript submitted to the journal, which deals with the issue of intravenous amino acid therapy for kidney protection in cardiac surgery patients. I am Reinaldo Bellomo, and I am one of the authors of this manuscript, which was under the driving force and enthusiasm of Dr. Gordon Doig, who has really been the major proponent of this kind of intervention. The rationale for giving amino acids to patients in order to protect them from kidney dysfunction arises from our understanding of renal physiology. It is now well known from multiple experiments that go back more than 30 years that in all human beings, the administration of either a meal of or intravenous load of protein, either in the form of fully formed proteins or in the form of amino acids, leads to significant changes in renal physiology. In particular, there is a significant increase in renal blood flow, which appears to be due to renal afferent arteriolar vasodilatation, and there is an increase in GFR. The increase in glomerular filtration rate, or GFR, has significant potential protective effects in terms of function in the setting of either critical illness or cardiac surgery, where opposing forces drive the status of the kidney towards afferent arteriolar vasoconstriction and decreased renal blood flow and decreased GFR. For these reasons, we conducted a pilot randomized controlled trial where patients were randomized to receive standard care or continuous intravenous amino acid solutions, with the goal of delivering approximately 100 grams of amino acids over that period of time. The infusion was given at the time of induction of anesthesia for cardiac surgery and continued throughout the operation and in the period thereafter until the patient was discharged from the intensive care unit. This solution is easily available. We used a Synthamine 17 solution, which is marketed by Baxter in Australia. And the cost is very limited, and it is a solution that's given as part of parenteral nutrition to many patients. And literally millions of people have been exposed to such amino acid solutions, but of course, not for the purpose of renal protection. In this study, we randomized 69 patients to receive either standard care or a solution of amino acids. Their standard age was between 70 and 72 years, and the distribution of many patient characteristics, including gender, weight, baseline serum creatinine, the degree of renal dysfunction at baseline, the estimated GFR at baseline, a history of chronic kidney disease, and other factors that might be relevant to the study outcomes were all very reasonably and equally distributed across the two groups. The primary outcome of the study was the duration of renal dysfunction identified as a creatinine greater than 168 micromoles per liter, the so-called Brussels criteria, over the period of observation in the 10 days after surgery. And according to the primary outcome, we were unable to detect a difference between the two interventions. However, there were also several kidney-relevant secondary outcomes, the most important of which was the duration of acute kidney injury as described by the KDIGO classification. The KDIGO classification comes from Kidney Disease Improving Global Outcomes classification, and it is now the consensus set of criteria for the definition of acute kidney injury. According to the KDIGO classification, the patients were randomized to the amino acid therapy at a significant decrease in the duration of acute kidney injury with a P of 0.037. Moreover, if this outcome was adjusted for a number of covariates that were present at baseline that were showing slight differences between the two groups, we were able to show that there was a significant difference between the two groups at a very low P of 0.0001. And also the duration of stage 1 acute kidney disease was significantly different in favor of treatment with amino acids. And coherent with this, there was a significant increase in urinary output per patient per day from 1,383 mils to 1,733 mils. And this was very much in keeping with all the other signals of potential renal protection. So we found ourselves at the end of this pilot investigation showing that there appeared to be several potentially clinically relevant physiological effects of amino acid infusion towards increasing markers of kidney function and increasing urinary output. Are there any side effects of amino acid infusion? The answer is that the major side effect that we were able to detect was increased urea generation. This is also a well-known side effect of protein or amino acid administration, and it had been previously demonstrated. In this setting, therefore, whilst there was an effect of this intervention on creatinine to lower its value or stop it from rising to levels of acute kidney injury, at the same time, there was an increase in urea, which did not reflect GFR. And this has some important implications for potentially larger trials to be conducted in the future. So to summarize the findings of this pilot investigation, we were able to identify a physiological and potentially clinically relevant effect of amino acid infusion in patients having cardiac surgery where the infusion was begun at the time of induction, continued during the operation, and thereafter in the ICU. This effect applied to the KDIGO criteria, to the incidence of AKI stage 1 according to such criteria, and to urinary output. It was associated with an increase in urea, which it was dissociated from the effect on renal function. These are important and useful insights into the pathophysiology of acute kidney injury after cardiac surgery and provide the basis for further investigation of this intervention in this unique population. Thank you for your attention.